due to RV and LA.
LA. Located upwards in the third intercostal space, you think of LA. And associated other.
Space doesn't matter, it's the same space.
No left ventricular involvement in case of mitral stenosis.
In relation to your cardiac cycle, it's a pre-systolic. Okay.
In a cardiac patient especially, you should definitely say whether S2 is palpable or not, or P2 is palpable or not. But do you feel any pulsation in the pulmonary, in the second space? So I think in your palpation, you should say left second space, P2 is not palpable, and no pulmonary artery pulsations. If the pulmonary artery is dilated or hypertensive, you can feel that.
Actually, I am surprised. Usually, invariably, students tell both in VSD, ASD, and mitral stenosis or mitral regurgitation, P2 is palpable. In thin chest wall individuals, a palpable pulsation, systolic pulsation, should not be misinterpreted as palpable P2. So, even in those cases, they mention it. Whereas here you have found epigastric pulsations and
no
parasternal pulsations and heave. So, it's important you mention about the intensity or the palpability of the second sound, as doctor mentions. Okay. Yes.
Even on percussion, three things. Left heart border corresponds to the apex. When will it not correspond?
Sir,
when will it not correspond? Why did you say it corresponds to the apex?
Pericard.
No, you said left border of the heart corresponds to the apex beat. So why did you mention that sentence? It means sometimes it doesn't correspond to the apex beat, right? So when does it not correspond? When you have pericardial effusion. So you should be able to say it loud, because that's what it means. Right heart border beneath the right border of the sternum. You should also percuss the second space, second left intercostal space, whether it's dull or resonant. When will it be dull?
Pulmonary hypertension.
Pulmonary?
Hypertension.
No. Because of pulmonary hypertension, you might have pulmonary artery dilatation. So pulmonary arterial dilatation. What else could give a dull second space? Pericardial effusion again.
Yeah, especially in this case, you mentioned one of the possibilities for chest pain at that period of time is possible pericardial effusion. It may not be massive in rheumatic heart disease, but in acute carditis there may be some collection. So naturally you will find that there will be dullness both on the right and left side in the base of the heart. Okay, yes.
And also lymph nodes. If there are mediastinal lymph nodes, it might be dull. So for each finding you mention, you should be, when the examiner asks you, you should be able to rattle out some things in relation to that. That helps you.
Order mainly pulmonary artery 2 finger space away from your midline.
Okay, sorry. From this, so what do we think this patient has? If we want to arrive at a broad diagnosis, which valve or what is involved? What do you think is the involvement?
Left-sided regurgitant lesion, most probably a mitral.
There is a regurgitant lesion on the left side because there is cardiomegaly.
You
left
start from
ventricular
the
type.
symptoms rather than your physical examination by regurgitation from your symptoms.
Progressive exertional dyspnea.
It can occur with stenotic also. Anything specific for a regurgitation?
Palpitations, chest
Palpitation,
pain.
right.
Volume overload.
It cannot be aortic, so probably mitral valve. So if you have a severe mitral regurgitation which worsening due to a recurrence of rheumatic fever, probably you could have all the features. Parasternal lift, there's a systolic thrill, and dilated left ventricular type of apex dilated heart. Okay. Now let's confirm the findings.
On auscultation, mitral area, S1 is soft, S2 is normal, holosystolic grade 4/6 pansystolic murmur, with systolic thrill is heard radiating to the left axilla and the left inferior angle of the scapula, heard best with the diaphragm of the stethoscope in the left lateral position. No other sounds heard. Lower left sternal border, first heart sound, second heart sound normal. Same murmur heard in the mitral area is radiated.
Yeah, one important thing is, if you are feeling systolic thrill and you are having a pansystolic murmur, which is heard, it's not necessary that you have to rotate the child to left lateral position. To hear a mid-diastolic murmur and the intensity of the first heart sound, sometimes it may be important in a child with failure, okay, to put in the left lateral position. But when you are having a systolic thrill, there is no need to shift the child unnecessarily. Okay, yes.
When do you say S1 is soft? Why do you say?
It is masked by the pansystolic murmur, starting
No, no.
soon after the systole.
How do you quantify it soft, normal, or accentuated?
In comparison
Compare
to
with
what
the
other sound?
S2.
Do you compare it with some other sound?
Compare with the S2.
In apical area, S1 is the loudest. Okay. Similarly, how do you say P2 is loud?
Compare with the A2 aortic component of the
Okay.
second heart sound.
Again, you can compare it with S1. If it's louder than S1 in apex, it's going to be loud P2.
Pulmonary area, first heart sound heard normal, second heart sound heard. P2 is loud. Ejection systolic murmur of grade 3/6 heard in the pulmonary area, best with diaphragm of stethoscope. Aortic area, first heart sound, second heart sound heard, no murmur. Per abdomen examination, upper abdomen is distended. Liver is palpable 4 centimeter below right costal margin in the mid
1 minute before you go to the abdomen, in the heart itself there is a mitral regurgitation. To quantify the severity of mitral regurgitation from clinical findings, if it is severe mitral regurgitation, in addition, what will you find?
You can
What
have
will be
a
the sound, additional sound, and what will be the additional murmur which will be heard?
S3 can be there.
S3 will be there, yes.
Can also
Big-
be a flow,
And there will be a mid-diastolic murmur due to
Mid-diastolic
relative
apical.
mitral stenosis. So you have to mention. So that
Not-
itself will tell you
Could
whether
not
the
be
child
heard,
is having a
sir.
significant mitral regurgitation or just mild, moderate.
You put it as S3 absent.
I could not hear, sir. No other sound.
So what
sir.
does it indicate?
Will
Absent
it indicate
S3,
some other problem in association,
absent S3 in a significant MR,
especially with failure?
you have symptoms, but clinically you don't see a S3.
Does it indicate possibility of any other this thing condition in association?
Any
mitral
associated
regurgitation?
finding or any associated lesion that is going to prevent S3 from occurring.
Anybody in the
MS.
audience? Any other student? Would you
No.
like to answer this question? This cardiology is echo.
Okay. It's associated mitral stenosis because S3 occurs during rapid atrial filling. I mean, that phase is cut with your mitral stenosis. So when you have a absent S3, you think in terms of associated MS.
Stenotic lesion.
What is
That
the
type
difference
of
between
MS will be
grade?
seen by echocardiography rather than by clinical examination. Later, once the failure is controlled, you may be able to hear the mid-diastolic murmur.
Difference between radiation and conduction. Sometimes you have to say conducted, sometimes radiation. So here you use two radiations.
What
One
is
the murmur.
radiation, what is conduction, what is transmission?
So same intensity is conduction. Reduced intensity is radiation.
What is transmission? Murmur is transmitted all over. Okay.
For abdomen examination, upper abdomen is distended, liver is palpable 4 centimeter below right costal margin in the mid-clavicular line. Firm, tender, smooth surface, rounded margins. Liver span is 13 centimeter, which is increased. No splenomegaly, no free fluid. Respiratory system examination. Respiratory rate is increased. Accessory muscle of respiration is in action. bilateral air entry present, fine crackles are heard in bilateral basal areas. CNS examination, higher mental functions are normal, cranial normal, has a limping gait, no involuntary movements, fundus is normal.
What is the normal liver span in this age group?
About 10 centimeters.
Huh?
10 centimeter.
She walks with a limp.
Because of the joint pain.
Uh-huh.
Because of the joint pain, sir.
Okay.
Respiratory system?
Crackles, basal crackles are there.
Crackles.
That's why I'm surprised when you said JVP is normal in spite of liver being enlarged this much and still crackles being present. Okay.
That is one. Second thing is, should you have mentioned something more in the respiratory system? Should you percuss the chest for pleural effusions? Because somebody in congestive cardiac failure, somebody was acutely destabilized, you should also look for pleural effusion. Abdomen, you should look for free flow. You mentioned that. Okay. So that's very important. Cardiovascular goes with respiratory system.
And if there is a significant pericardial effusion, let us say, of course, the cardiac size is not markedly enlarged, okay, and you are able to feel the apical impulse easily, and then you find the murmurs and all. Let us say there is another child with rheumatic cardiac moderate effusion. So what will be the other lung signs? So secondary to pericardial effusion, there will be some lung signs described in text, clinical methodology. What are the things? So apart from pleural effusion, so what else you will see if there is a pericardial effusion of moderate size? There will be a relative compression of the left lower lobe, so you will find a bronchial breathing. What is that sign known as? Ewart sign. So you must be able to find out there is a relative collapse. Okay, so you may be finding that particular finding. Yes, proceed.
To summarize the history, 11-year-old female child belonging to lower social economic class, presenting with gradually progressive exertional dyspnea and chest pain, fever, arthralgia of short duration. Examination showing pallor, undernutrition,
Okay.
pansystolic murmur in the mitral area and an ejection systolic murmur, loud P2 in pulmonary area with bilateral basal fine crackles and tender hepatomegaly. I would like to think in terms of mitral regurgitation as the cause, probably of a rheumatic origin with pulmonary hypertension and congestive cardiac failure.
It says now pulmonary hypertension.
In sinus rhythm with no signs of infective endocarditis and active carditis due to recurrence, and also there is anemia and underweight.
We are
What
doubtful
are the
about
features of pulmonary hypertension in your clinical examination?
Chest pain can be due to pulmonary hypertension.
Pardon?
Presence of ejection systolic murmur, palpable P2 and RVH, parasternal pulsations.
Can't you be confident about your diagnosis of rheumatic or rheumatic mitral regurgitation? Why you say probable? The child is having active arthritis and the symptoms. Okay, it's not rheumatoid arthritis. Rheumatoid arthritis usually they don't present at this stage with mitral regurgitation. They may present with aortic regurgitation later on. Okay, though mitral regurgitation can also occur. So you are not thinking of mitral valve prolapse because it's a pansystolic murmur. There is no Marfan's or other dysmorphic conditions, connective tissue disorders. So why still you want to put probable? You think that we can diagnose only after some of the investigations? So you can confidently say rheumatic origin because of the age and the country where we are in now. Though of course the incidence of rheumatic fever has come down. Pulmonary hypertension, when we asked you, you find that there is a parasternal heave and epigastric pulsations, evidence of right ventricular hypertrophy. You said it's a left atrial enlargement which is transmitting the impulse anteriorly. But you said the pulmonary second sound was not palpable and not loud.
It was loud sound.
That could be due to failure, cardiac failure. Sometimes the intensity of the sound can be impaired because of the significance of the failure. But then, of course, you have invited a diagnosis of pulmonary hypertension without, so That of course has to be considered.
Auscultatory finding should be there for pulmonary hypertension. At least P2 should be
P2 was loud, sir. It was
loud,
not
huh?
palpable.
Okay, okay. And why do you say sinus rhythm?
Rhythm is normal. There is no
It could be
irregularity.
just junctional rhythm at 110 per minute. Clinically, have you missed something?
Alteration with
Which
inspiration.
favors a sinus rhythm?
Alteration of the respiratory pulse rate with the
No, that's not
respiration.
important. Any physical finding which you said was normal, you could have just put
Res-
in few details.
sleeping pulse rate.
Huh? Your JVP, when both waves are seen, A and V waves, it's sinus. Just with a rate, it can be still any arrhythmia with a associated block, or a junctional rate with digitoxicity. It can present at this rate. Okay.
Look for Cannon waves also. Suppose if it is a junctional rhythm or any other rhythm other than sinus rhythm, you can have Cannon waves. You know what Cannon waves are?
Large A waves.
Large A waves due to atrial contraction against a closed tricuspid valve. So that might suggest it is not a sinus rhythm. And the volume, whether the pulse volume is equal or unequal, also might suggest some arrhythmia other than regularity.
So even in normal JVP, you mention about waves. So how do you manage?
First, confirm the diagnosis. We have fever and arthralgia, so supporting evidence for antecedent streptococcal infection has to be there to rule out, as we are suspecting a recurrence. But it's not a polyarthralgia, monoarthralgia, so we do inflammatory markers, CRP, ESR.
Okay, we all know about the Jones criteria and all those things. How can you, do you know of any other guidelines which give some leeway so that you need not follow the Jones criteria, or there are some guidelines? Because there's a lot of discussion as to should any rheumatic fever child should fit into the Jones criteria.
In presence of chorea, indolent carditis,
Yeah.
and recurrence, all the criteria need not be satisfied.
Have you read about the Australian guidelines?
No, sir.
No, because actually there's a lot of debate even for infective endocarditis. I think all of us should know. In clinical life, we cannot be following something very rigid because patients are patients and they have a lot of variation, socioeconomic variation. And most of these guidelines come from the West, where the socioeconomic status is different. So many people say we should follow many of the Australian guidelines, which are actually for people from the Aborigines and other immigrants. In fact, for infective endocarditis, they're slightly different. The latest guideline from American Association of Cardiology is that you don't need to give infective endocarditis prophylaxis for most of the cases, whereas Australian guidelines make a leeway for Aborigines. Same way, high risk group for rheumatic fever have some categories called probable, most probably rheumatic fever, because they found many patients have features of rheumatic fever, but really no rheumatic fever. But initially, the clinicians suspected rheumatic fever, but did not fit into rheumatic fever guidelines. And they followed up, and they repeated echo and all those things after about 2 months, and they found really they had rheumatic fever. What they had was rheumatic fever. So those features are considered as probable rheumatic fever. Now we should just be aware of those things. That Australian guidelines are it gives way for making diagnose a rheumatic fever when the actual criteria are not there.
post-streptococcal reactive arthritis. Even though it doesn't fit into Jones criteria, it has some indications for penicillin prophylaxis.
Okay, quite a good complete presentation. Thank you.
Thanks.
Little more confidence is necessary. Other than that, so you should be more authoritative in your presentation, so that examiner should feel scared.
No, appears probably.
Size, like this.
Thank you, Dr. Shruti. I request Professor Srinivasan to please give the gift of appreciation to Dr. Shruti. I now request Professor Srinivasan to please hand over a memento to Dr. Jabraj. I once again request Professor Srinivasan to please give the token of appreciation to Dr. Jnana Sambandam. I now request Dr. Jnana Sambandam to please give the memento away to Dr. Srinivas. Thank you.